Kia ora everyone, welcome to the Goodfellow Unit Webinar tonight. We're speaking on common urological conditions that we see in primary care. And with us is Dr. Andrew Williams. He's a specialist urologist at Counties Manukau and Auckland District Health Board. Welcome, Andrew.
Thank you.
So without further ado, I'll pass on to Andrew.
Thanks, sir. So I'm just going to give a bit of a talk on common urology conditions. And basically, I just want to try to simplify some of the areas of urology, because in the bottom line is that urology is one of the simplest sort of specialties. It's not really that many things that can go wrong. And I'm just going through some common things that you guys may deal with. A couple of things just to note. First of all, everyone has biases when they talk about things. I'm a urologist, but specifically I do a lot of uro-oncology and cancer work. I do a mixture of public and private. I examine for the college and been involved in training. But probably the notable things is I'm chairman of the National Urology Tumour Standards. So basically at the moment we're going through all urology cancers, trying to standardise the treatment so that we can get sort of equity across New Zealand, and also some quality improvement. And so part of that is sort of making sure that everyone from GPs to radiology to nurse practitioners to urologists to radiation oncologists all are sort of working on the same sort of playbook. And I just do a bit of medical advice for Prostate Cancer Foundation, and mainly I'm a moderating force sort of there, because I'm not a strong proponent of prostate cancer screening, but really sort of just trying to improve the care of these patients. So as I said, my main aims today is really to simplify what's a pretty simple specialty. Just give some little basic treatment algorithms for how you deal with some common problems, and look at indications for further investigation and why. And it's just most notably, I think, really in regards to urinary tract infections, but also, the reasons why we talk about elevated PSAs would need to be investigated. And just a quick chat about some new investigative and treatment options. So three main groups really here: prostate cancer and PSA. And I'm not going to dwell on the whole PSA screening debate, because I think we could be here for hours on end discussing that. Some male low urinary tract symptoms and some recurrent UTI'S. So once again, I said I won't go into the whole prostate cancer screening in depth, otherwise we could spend this entire time talking about that and also discussing the pros and cons of it. But nearly all international bodies now recommend that PSA testing is sort of offered on a risk-benefit discussion basis. I don't think there's any body that recommends population-based screening. And it's really the risks are really the morbidity of the biopsy and the risks of over-treatment. So basically you cause harm by doing a biopsy, but also if you pick up a cancer that doesn't need treatment, that you end up over-treating and causing harm in terms of incontinence, impotency, and men that would never have died from their disease. The biggest reason for this is that low-risk cancer, which is actually present in about a third of men over the age of 60, is sometimes found. People want to have it treated because it's a cancer, and you end up creating more harm than good with this. The key to understanding this is really this figure here, and I often show this at talks, and this is data that's never going to be repeated because this is observational data of prostate cancer treatment. So if we look here on the side, this is the aggressiveness score of the cancer. Basically at the top here we're looking at not very aggressive cancer down to the more aggressive ones. And these boxes are each 5 years. So you're looking at 5, 10, 15. Now red is your chance of dying from cancer in those periods of time. The sort of pinky color here is your chance of dying from something else. And the white is your chance of being alive at the end of it. So if you take somebody, let's take this is a 55-year-old man, these are the ages at the top here, who is diagnosed with Gleason 6 prostate cancer. In 15 years' time, he has about an 8% chance of dying from prostate cancer. His chance of dying from something else is about 12%. And the reality is our low-grade cancers these days really fit in more this sort of group. So the chances of dying from low-grade cancer at 15 years is 1 or 2% versus a lot higher chance of dying something else, and even a more higher chance of being alive. The group that we want to actually look at for treatment for prostate cancer is these ones at the bottom. These are high-grade prostate cancers. So if I see a 55-year-old with a high-grade cancer, in 15 years' time, he's got about a 70% chance of dying from prostate cancer, and a 10% chance of dying from something else, and about a 18% chance of being still alive. So these are the people that you're actually going to make a difference to their life expectancy. If you treat these people up near the top, all you're going to do is make their life miserable and make very little difference to their life expectancy. We talk about PSA tests. As urologists, our perception of an average PSA is someone with a PSA of about 4. The reality is this is nationwide data from the US looking at the average PSAs. You can see here the peak PSA is actually only about 0.6. And so this is your risk of developing prostate cancer metastases over your lifetime. And you can see here that although this is the half the population sits at this low rate, you look at the chances of them getting death from prostate cancer and it's very minimal. But as you go up the PSAs to our threshold, which is currently set at 4, they've actually got quite a high lifetime risk of prostate cancer. So really, PSAs are not a particularly good sort of a marker for finding prostate cancer. But one of the things that we're looking at is whether or not people with a low PSA ever need any tests, because their lifetime risk of prostate cancer is so low that probably going to cause more harm doing tests on them. And that's something that will probably work into sort of if we ever do get to a place of offering prostate cancer screening. In New Zealand, there's been a move to standardise prostate cancer referrals. So these are very brief numbers. If you're under 70, your PSA should be less than 4. If you're 70 to 75, we increase that cutoff to 10 before they get reviewed. And that's really because there's not a lot of evidence to say that patients with a prostate cancer in their 70s actually benefit from any treatment. So they have to really be on the nastier end of the spectrum before you start considering treatment. The other thing that we look at is over the age of 75, and we increase that PSA again over 20 because there's really no evidence to say that we improve life expectancy in people over 75 by testing them for early prostate cancer. And so you're really only looking at hormonal treatment to slow down a prostate cancer. And on average, if you start hormone treatment to slow down prostate cancer, you're talking about 13 years life expectancy. And the reason why that 75 numbers picked is your average life expectancy of a 75-year-old is about 88. So you're looking at really just playing the odds. But the important thing just to note in your practices is that any patients with an abnormal prostate examination or other clinical concern should be considered for referral. So although these sort of guidelines are in place, there's no reason why, if you're worried about a patient whose PSA has gone from 2 to 4 in 2 years and their father died of prostate cancer at the age of 60, why they can't be referred. You just need to say that there's clinical concern, and these have been adopted nationally as the guidelines at this stage. Just a quick note on examination, because we see a lot of people who are terrified about prostate examination. So when I worked in Canada, we used to run an education service for the medical students where we actually got volunteers to come in for prostate examination. And these sort of quite generous men would come in and they'd be examined 3 times a year. And, about 50 medical students would sort of put their fingers up their back passages. And they all felt that the best way for examination was as described here, which is on the side, knees tucked up to the chest. When you tuck up the knees to the chest, it relaxes the buttocks. It sort of forces the buttocks to relax. If you often have people bent over a bed, they sort of clench their buttocks more than anything else. So lots of lube. If the anal canal tightens, you just wait, and you don't have to push, you just wait until it relaxes. And what we're actually looking for here is, this is basic anatomy of the prostate. This central zone bit, that's where you get enlargement, non-cancerous enlargement, and it causes like a tight collar for the urine output. But the cancers all occur in the outside in this peripheral zone here. So most cancers actually are palpable. And so that's because the part of the prostate which is exposed to examination is the part that's most likely to have cancer present. And here's just an example of what cancer feels like. So it can be hard and irregular and gritty. And you can see here that this is all the cancer all through here. There's no difference to the outside of the prostate. So you're often looking, the first thing you notice is it's just harder than the other side. But in its advanced stages, it causes distortion, but it often doesn't really cause gross distortion until very late. Whereas non-cancerous prostate glands are like, here's a picture of one here. You see how you get these fleshy nodules? So they're quite soft, They feel a little bit like the base of your thumb, you know, quite sort of rubbery, and they can cause quite a change to the shape, but the most important thing is that they still feel soft. So how do we improve all of our investigation of prostate cancer? Well, the biggest problem with this is that you don't want to find cancers that are never going to make a difference. So I just wanted to highlight the main areas where things have just changed recently, and you'll see it in your patients coming through, is looking at MRI scan to only biopsy those that need it, to reduce the morbidity of a biopsy, because it's a pretty unpleasant thing, and guys sort of sit around drinking beers, sort of telling everyone about how bad their prostate biopsy was. And the other thing is treating only those patients that really need it. And part of that is really at the urologist and radiation oncologist end. It's also patient education. We know that if we end up getting a nurse practitioner to discuss prostate cancer treatment with a patient, they're actually more likely to opt for no treatment. And that's actually a good outcome often, because these patients are, often they hear the word cancer and they want to have treatment, regardless of whether or not that cancer is any risk to their life. And the other thing is we do some better tests to look to see whether it's an isolated cancer or whether it's spread. So what we tend to do now is a multiparametric MRI scan. So if some people talk about an ultrasound for like diagnosing prostate cancer, and to be dead honest, a transrectal ultrasound in prostate cancer just shows us where the prostate is to put a needle in. There's no diagnostic sort of ability in a transrectal ultrasound. MRI scans are actually pretty good at finding cancers that you want to find. They're not very good at finding low-grade cancers, and that's actually an asset with this test. And the real thing that's changed is all these, we call multiparametric. So you're looking at multiple parameters looking at the same tumour. And it's changed MRI from being pretty useless 10 years ago to being actually very accurate, and probably more accurate than biopsy now for determining whether there's prostate cancer present. You can see here on these different views the different sort of responses of the prostate cancer tissue to the in these different phases. It is, however, very dependent on the radiologist. And if it's normal, you're very unlikely to actually have cancer on a biopsy. So you can actually reduce the number of patients needing a biopsy by about 30 to 50%. So you're actually reducing the morbidity, because not only are you not doing a biopsy, but you're not finding low-grade insignificant cancers as well. The other thing too is it actually localizes the cancer. So your chance of missing the cancer is a lot less. Everybody talks about a transrectal biopsy. It's been the standard of care in urology for many years. It's a pretty brutal procedure. You know, no one would ever suggest putting a needle through the rectum as a clean way of doing things. And our infection rates sort of fit with that. You know, 4 to 5% of patients get admitted to hospital with sepsis, and that should actually be an ICU admission rate. We have about a third of those patients go to hospital, go to ICU for inotropic support. You know, it's pretty major morbidity for a diagnostic procedure. Its accuracy, depending on who you look at, is sort of 60 to 90%, but the main advantage is it's cheap. You know, it costs about $800 to the hospital. I haven't done a transrectal biopsy in private now for 2 years, and the reason for that is that we have full funding for transperineal biopsies in private, and at the moment we're sort of in the process of transitioning in the public hospital, but it's a much more logical way of biopsying a prostate. It is done under general anaesthetic, but the reality is if your patient is not a candidate for a general anaesthetic, they're not a candidate for finding a cancer in this situation, you know, because it's not going to, if they have contraindications to a general anaesthetic, you're not going to, their life expectancy is going to be less than 10 to 15 years, and you shouldn't be looking for cancers in them. Rather than going through the rectum, you put the ultrasound probe in the rectum, but then the needles go through the skin into the prostate. So you can clean the skin, so the rate of sepsis is essentially 0%. It's far more accurate, but the biggest issue is the cost. And there's certainly, I think in 5 to 10 years from now, we'll only be doing transperineal biopsies, because you just can't make an argument for a transrectal biopsy other than on the basis of cost. The other area where we've improved is these PSMA PET scans. So once you've actually found a cancer, then you've got to look and make sure whether it's actually localized to the prostate. If it's not, it doesn't matter what you do, surgery, radiation, the horse is bolted, and you're actually just causing harm by treating these people. We recently just completed a study in Auckland where we looked at people with prostate cancer and who had traditional staging, which is CT scans, bone scans, MRI, and then we managed to get funding through the Prostate Cancer Foundation for these to have these PET scans. Now they cost $2,500, but in 1 in 4 patients, it stopped them having needless surgery. So you can see on here that this is a wee tumor in the bone that was missed on a CT, and it lights up like a Christmas tree on these scans. And so it's really very accurate for looking at metastatic cancer. And so we're reducing the morbidity once again by improving the patient selection. So really, if we look at the standard of care for investigations, we talk about a raised PSA or abnormal digital rectal examination triggers a review. And so we're not, in the past, what we'd say is that triggers a biopsy, and that's a pretty brutal way of looking at things. So now what we typically do is we review them. If an MRI scanning is now the initial sort of screening test as such, because what you know is that if the MRI scan's normal, you don't need to do any more tests. You can just continue monitoring things. There are some cost implications, but we're dealing with that on a national level. But then if the MRI is abnormal, then you'd be looking at a transperineal prostate biopsy. And at the moment in Auckland, we're probably getting about 1/3 to 1/4 of our patients getting transperineal biopsies in the public service. And as I said, in private, it's nearly 100%. And then once you've found the cancer, you get one of these PSMA PET scans, and they're the standard of care in private and public. We're currently sort of looking at finalising funding for that, but there are volume issues with that. And you only treat people that have intermediate or high risk disease. And the treatment of low risk cancers is really needed. And this is one of the things where actually your GPs can help with a lot, because these patients often will come back to see their primary care provider to discuss things. And the last thing you want them to do is come back and you just say, oh no, it's a cancer, you need to have treatment. These low risk cancers are probably no risk to the patient's long-term life expectancy. And as I said, treatment can cause harm. And it's not that we forget about these, we just monitor them to make sure that we haven't got the diagnosis wrong in the first place, but we just sort of sit back and observe.
Can I just interrupt? We've got one question about the PSAs, the rate of rise of the PSA and whether that influences the likelihood of there being disease.
Yeah, we've had long discussions about whether or not to include a rate of rise in the national guidelines. Now, if the rate of rise concerns you, then send a note to a urologist. That's fair enough. And there is not a lot of good data to say that the rate of rise actually is a good predictor over on top of PSA. Because the reality is PSA is a rubbish test. It doesn't matter how you manipulate a rubbish test. It's still a rubbish test. So certainly if you've got a consistent pattern and you're concerned, that's the ideal situation where you do an MRI scan, because you've got a normal PSA. And if the MRI is normal, you'll just continue monitoring things. If the MRI was abnormal, then you've actually got something really early. And a lot of people have discussed, whether or not you're missing the boat by you're waiting till the PSA gets to 4.5. There's no evidence to say that waiting till the PSA gets to 4 actually is any harm. If you diagnose it when the PSA is 5, the chance of cure with local treatment is so high that there's probably very little risk in waiting a bit longer.
I think that answered the other question about avoiding finding low risk cancers before they become high grade. So I think you just answered it through there. And the one last one here, which is, can you get a high grade cancer with a normal PSA?
Yeah. PSAs, as I said, they're as good as we've got. But I often talk to patients saying it's a little bit like a cholesterol. Just because you've got a high cholesterol doesn't mean you're going to have a heart attack, and just because you've got a low cholesterol doesn't mean that you're not going to have a heart attack. It's a risk factor, and it's one of the things that I try and sway the sort of thinking of things is that you look at PSA tests as being a risk factor. Just like having a BRCA mutation in the family is actually a risk factor for prostate cancer. What we want to do is we want to evaluate those people that are a high risk. Whereas, in times where people have used PSA as a screening test, which is never what it was designed for, never what it was intended for, but it was just uncontrollably introduced on the market, really.
And I think what you've alluded to here, what someone else has said along the lines of that it shouldn't be offered per se as a screening test. It should be discussed possibly, exactly. And only done when you've had that discussion about the risks and benefits with patients, rather than it being a screening automatic test.
Yeah, exactly. And unfortunately, the PSA tests, they were introduced uncontrollably. And one of the difficulties is that patients will always have their own views on it. And the last thing you want is someone that comes along and wants to have a PSA test and you say no, and then they come back complaining after they've been diagnosed with cancer. It's an awful situation to be in. In an ideal world, we would ban PSA tests and then we would start from scratch and do a study as to its evaluation, but we can't do that.
Okay, great.
All right. So just to change tack, just talk about some men with urine symptoms. So we see a lot of guys with urine symptoms, and it's just working out what's going on. And broadly, I like to split into 3 areas. So polyuria is probably something that we don't see quite as often as in general practice, but you guys would see it a lot more. So you're looking at diabetics, patients who are taking diuretics at the wrong time of the day, people with pedal edema, and also some people develop nocturnal polyuria. So the polyuria needs to be distinguished from urine symptoms in a guy because they do get treated quite differently. The other symptoms you're looking at are storage symptoms. So there's two parts to peeing. Obviously there's the power from the bladder pushing the urine out, and then there's the outlet, which is the actual voiding bit, which is basically how tight the channel is on the outside. Now, if you in storage symptoms, you're really talking about a bladder overactivity, so the bladder wanting to pee at the wrong time, or a small bladder that won't really hold much urine. And that can either be because it is just a small bladder, or because you've got a retained volume of urine, which it means that you might have 400 mils left in a 500 mil bladder, and if you can't empty that 400 at all, you're essentially got a 100 mil bladder because it's just going 400, 500, 400, 500. The other side that people often talk about is the voiding symptoms. So you're talking about, obviously your bladder needs to push urine out, but that outlet needs to be open. And that's really what the primary symptoms are of prostate hypertrophy. So polyuria is saying a normal bladder holds about 300 to 500 mils comfortably. The people do get much higher than that in extreme cases, but if a patient creates 1,500 mils of urine overnight, they're going to go to the toilet 4 times overnight. And it doesn't matter what you do to their urinary tract. The issue is actually the urine volume. So sometimes what you can do is ask patients who complain of nocturia is to just go to the warehouse and buy a 2-litre jug and put it next to your bed and pee in it overnight. And then in the morning, you actually know how much urine they've actually peed out overnight. There are some people who, that their kidneys start working 24 hours a day as you get older, and often they only work at night. So these people will not pee at all during the day, then they'll go to bed and they'll start peeing, creating urine. And so you can try in these polyurics to just get them to elevate their legs after dinner. If they're taking diuretics, you can try putting it on in the afternoon so that they essentially dehydrate themselves before they go to bed. Compression stockings can often help, and stopping coffee or tea or other drinks in the evening. And what it is basically they're storing up fluid during the day, and then they lie down in bed, gravity goes off those ankles, they start, all that fluid gets mobilized back into the bloodstream and they pee it out overnight. And you can often get this even with people who have no clinical evidence of edema, and it's just a simple thing that you can try. Storage symptoms. We talk about urgency, frequency, and urgent continence. So the urgent continence means, I need to go to the loo, I'm rushing, oh, there it's gone. And they can either be primary problems from the bladder, but more often than not in men, it's secondary to prostate obstruction. So you can imagine that your bladder's spent its whole life pushing really hard, the muscles get really big, and you get these hypertrophied muscles, sort of like a weightlifter, sort of these muscles are twitching, they want to fire off, and so they fire off inappropriately and want to go to the toilet. people with storage symptoms really need to stop coffee, tea, and alcohol. They're really bad precipitants of it. But it's worth treating prostate symptoms first and then for this. So you can give them an alpha blocker. And a lot of them will improve just with an alpha blocker, even though their symptoms are primarily related to their bladder. You can then add in an anticholinergic if you need to, sort of oxybutynin or solifenacin. The people often worry that they'll put them into retention by giving them an anticholinergic if they've got BPH. But the reality is that if they're that bad that they've gone into retention, they were going to go into retention anyway, and so they would need some probably surgical management of their outlet if that's the case. When we talk about flow symptoms now, it's easy for us urologists because we can pee in a machine and we can actually see a graph of how they pee and how fast they pee. But most patients actually have very bad flow when they start complaining about it. So, if I look back when I was a junior registrar, I could hit 50 mils per second on my flow rate. I'm only just coming up to 40 and I can hit about 30. I've noticed no difference in that time. Patients don't actually notice much difference till they get down to about 15, which is actually the definition of obstructed. And people aren't really bad until they get around 6 or 7. So they're actually at 6 or 7, they're 5 times slower than they were when they were younger. So you can often ask these guys, how far back from the toilet do you stand when you go for a pee? If they've got it really bad, they'll be sitting over the top of the toilet or they'll be sitting down. Can you write your name in the sand? Well, the main thing is that tests steadiness of the flow of the urine, and guys know about these things. They'll be able to tell you. People often talk about peeing over a fence, but the reality is I probably can't pee over a fence anymore, and I don't think I need anything done. But the other thing is guys with poor, really bad flow don't use urinals. So if you ask them, whether you pee in the urinal at the rugby, and they say, no, go and sit down, that means their flow is pretty bad. So we manage that with alpha blockers, finasteride. And those of you that are familiar with finasteride, it's actually the only drug we can use that prevents surgical management of the urinary tract. And so any patient that has a prostate of 2 fingerprints on each side, which is basically 40-gram size prostate, should be considered for finasteride because it will reduce their need for surgery in the long run. And that's available as a special authority for patients that have symptoms not controlled with alpha blockers. And even if the cause of poor flow is that the bladder is a bit weak, you still want to deal with the outlet because, if the bladder is weak at pushing things out, it'll do a better job if the outlet's easier to pee out through. So basically polyuria is conservative measures, leg elevation, compression, modify the urine fluid intake, reduce alcohol and caffeine, can change the timing of the diuretics. Sometimes when we're urologists, see these patients with polyuria, we're a little bit iffy about starting any diuretics because we're obviously not their primary care physician, and if something goes wrong, it's not going to be our problem. So don't be surprised if you do sort of get a note from the urologist saying, look, could you consider starting some afternoon furosemide, 20 milligrams at 3 o'clock in the afternoon, see how he goes. Because basically we realize that we can't really follow it up sort of appropriately. Storage symptoms, you start them on an alpha blocker, then you can add an anticholinergic. If they're still getting problems, send them to urology because we can actually do formal tests to work out what is actually the problem, because sometimes patient symptoms don't match up with actually what's going on. But if they've got hematuria with storage symptoms, they really need to be seen quite promptly. Flow symptoms, alpha blocker, then you add finasteride, and the studies actually show you should probably start them both at the same time, but for funding reasons you do need to quote unquote have uncontrolled symptoms with an alpha blocker. And then if they're on alpha blocker and finasteride, the only other option to improve their flow is a tip. But watch out for patients that get nocturnal incontinence, because nocturnal incontinence in men is overflow retention until proven otherwise. Recurrent infections, because recurrent infections in a male are retention until proven otherwise, and catheterization. They're all reasons why we would jump in and do surgery early.
Andrew, I've got a couple of questions about the medication. One, is there a limit to how long you can use the finasteride for?
No, No. In fact, finasteride works most efficiently if you just stay on it for the rest of your life. It takes 3 to 6 months to take effect. So the patients are all, we warn them all, look, you'll notice nothing for 3 months, and you'll start noticing an improvement between 3 and 6. At 6, it'll reach maximum effect.
Okay. And at what doses of doxazosin would one consider going to finasteride?
There's two ways of answering this. The reality as far as pharmac goes, you should go to maximum tolerated blood pressure. I seem to see people with an enlarged prostate. I start them on doxazosin. I see them back a few weeks later, and I say, "Oh, your waterworks must still be terrible. We'll have to add some finasteride in." And the reason for that is doxazosin improves symptoms in the short term. It has no impact on long-term progression. So you make the patients feel better by giving them doxazosin, but their chance of surgery in the future is still significantly elevated as opposed to if they were on finasteride.
And there's a comment about there's a lot of possible side effects of finasteride, but do you find it causes or worsens depression, or have you heard of that as a potential side effect?
I've heard about it. In my experience, I haven't noticed it, but to be dead honest, I wouldn't be the person that would notice that. Okay. That would be you guys. I do warn them all. I say, look, 5 to 10% of people will notice some change in their erections or their ejaculation. That varies from person to person. It can be all sorts of things. If you notice a change, it could be the finasteride, and let me know, and we can talk about stopping it.
Okay. And there's something on post-finasteride syndrome that they understood a study is being done on this.
Yeah, this is back and forth. There's a lot of debate about it. The jury's out as to whether finasteride can cause some irreversible problems in this, and so I assume they're talking about erectile dysfunction here. The difficulty is that patients that are starting on finasteride are usually those that are starting to get erectile problems. They're the over 50s, 60s. The jury's out, but I think most people feel that it probably doesn't cause any long-term sexual dysfunction.
Okay. And if you know they are retaining, should you still start it?
Still start finasteride? Yeah.
Okay.
So if we look at if I did an ultrasound of everyone over the age of 60, everyone's got will have 100 mils. That's pretty standard. You'll often find on the radiology report that the radiologist will say significant post-void residual volume. The reality is that we don't get too worried if it's anything under about 250 mils. If it's over that, we tend to only be worried if they've got recurrent infections, bladder stones, or abnormal renal function.
And last one, do you use phosphodiesterase inhibitors?
No, there's been a lot of money in being pushed around this. Financially, it's just a no-brainer. It has an effect. There's no doubt about that. The cost is significant, and the effect is probably not borne out by the cost.
Great, thank you.
So recurrent urinary tract infections. So men are quite easy to deal with this. If a man gets 2 or more UTI'S, they need an ultrasound and they need a referral to a urologist, because usually if men are getting urinary tract infections, there's an anatomical problem. And that's really where urologists come into with recurrent urine infections. Our job is to fix anatomical problems. Women with 2 or more UTI'S in 6 months should have an ultrasound, but they don't need referral unless they fail further treatment. And I'll have just a wee chat about why it is that we do that. But obviously you want to rule out, in patients who have no growth, they should be referred. And obviously you would need to rule out chlamydia in those patients with no growth. Because one of the things that's difficult is there are 2 problems. There's cystitis and then there's urinary tract infections. So at a primary healthcare level, all of the patients the vast majority of the patients that you see with cystitis, it's from a urinary tract infection. At a urologist point of view, and why we like to see these patients that are a bit unusual, is there are many other causes of cystitis that are non-bacterial. And the one that's most concerning always for us is bladder cancers, but also sigmoid diverticular fistulas, radiation cystitis. There's some viral causes. There's eosinophilic cystitis. There's a whole bunch of other things that we look for. The reason why we suggest doing an ultrasound is that an ultrasound will rule out the majority of causes of reversible recurrent urinary tract infections. So what we're looking for is an anatomical abnormality of the urinary tract. So it will show you incomplete bladder emptying. It will show you obvious significant kidney stones. It will show you obvious significant bladder stones, and it will often show you obvious anatomical lesions of the bladder. And so you're talking about bladder tumours, you're talking about diverticular of the bladder, and often it'll show you things like if there's a fistula present, because you'll see an inflammation in a thickened bladder wall. A normal ultrasound rules out all of these things, but men should still be referred, because men, as I said, men often have an anatomical abnormality present. But if a lady has a normal ultrasound, then you can go down to the next step. So a lot of guidelines say that not to do urinalysis on ladies with urinary tract infections. From a cost-effectiveness point of view, it's not worthwhile doing, and that's reasonable in most people. But if you're starting to get someone with recurrent urinary tract infections, we really like to get a bank of sort of what bugs they're growing. You know, particularly, you know, we want to know if it's a Klebsiella or a Proteus, all these stone-forming organisms. So if someone's starting to show a pattern of recurrent UTIs, it's really nice if we can get some growth from them. You want to know whether it's precipitated by coitus, because most, what you can do is give them trimethoprim or something to have at home after they have sex, and that will control things. You can try Lovastin cream if the vaginal mucosa is of poor quality, varying success with that. But the main thing, as I said, is we want to know if it's the same bug all the time. So once someone's getting recurrent urinary tract infections, a post antibiotic urinalysis does actually help us out quite a bit, because some patients do need an eradication course of antibiotics. We would give them a 4-week course, and that will sort of control things. And it must be something in their anatomy where they're harboring some bugs which aren't being treated adequately with a standard course. So if a lady has recurrent UTI and a normal ultrasound, we've also often talked about the previous standard of care as going on a course of prophylactic antibiotics. Now, that particularly in this day and age, that's not a very nice way of managing things. So often these patients, we consider a home antibiotic initiation. So they give a little course of antibiotics and a urinalysis at home. So they notice the symptoms, they take off the urine and they start the antibiotics, and they bring the urine in the next day. This is really more about actually them getting on with their life as much as anything else, because there are a lot of patients that actually, if they can get immediate treatment, they actually can manage this quite well. But of course, the long-term antibiotic use has drawbacks of resistance and GI effects, thrush, but there are now a couple of other options which I'll talk about. And D-MANNOSE is the one that first of all I'll chat about. So I'm a bit of a skeptic when a lot of these things sort of come along, because it's such a common problem, but yet, you know, people come up with these simple solutions. So D-MANNOSE is a little bit unusual. What it is it's basically a sugar, but it is secreted in the urine hole. It's not like a glucose type sugar, and it doesn't affect diabetes or anything like that. But E. coli binds to D-MANNOSE. So there's some studies that show that's equivalent to prophylactic antibiotics in a blinded randomized trial, which is quite a significant result, because it's currently unfunded. You can, if you look around, get it for about $30 a month. We haven't really found any difference between any of the different D-MANNOSes. I think a D-MANNOSE is a D-MANNOSE, but a lot of patients are prepared to pay that, because, as I said, it does work. The other thing that has even surprised me more that it actually works is UROMUNE vaccines. So what these things work is they basically priming the immune system against the bacteria. So a simple thing is to spray under the tongue, and there's a very complicated diagram here, but basically what it does is it induces an immune response to the bacteria within the urinary tract, which actually helps the body deal with the infections. And it's aimed at a bunch of bugs, and this is why it's quite useful for us to know what the history is from a bacteria point of view. There is a broad spectrum one, which is E. coli, Klebsiella, Proteus, Enterococcus, but you can get specific vaccines for these. And you just do a 3-month sublingual treatment, a bit of a spray under the tongue. It tastes like pineapple apparently, but I haven't tried it. But the interesting thing is there's been several studies that have replicated that in patients with recurrent urinary tract infections, 90% can make it 12 months without any further urinary tract infections. It's currently unfunded, but we're working on it, and we actually have availability of it here in Auckland. We have patients flying from Australia to New Zealand to pick it up because it's not available in Australia at the moment. And I was very much a skeptic on this, but I have been very surprised at how well it works. And a lot of patients are prepared to wear that cost. It has been very difficult for us to get insurance to pay for it, but as I said, we are working to see whether we can get approval for it nationally. So basically, when we look at urinary tract infections in women, 2 infections in 6 months, they should get an ultrasound and start sending some urinalyses. Consider your postcoital antibiotics or Ovastin. But if the anatomy is normal, the standard options of the home antibiotics and the prophylactic antibiotics really are cost options. But MANNOSE and UROMUNE vaccine should really be considered in patients that can afford it. Unfortunately, as I said, they are expensive at the moment, but with any luck, that will come down.
There's a couple of questions there, yes, which is where do patients access the vaccine and who is the supplier? Other than through your urologist.
Yeah, look, we supply it through our practice. We don't do it as a money earning thing. We're more than happy for anybody to supply it. I'm not sure actually who we get it through at the moment. Okay. But as I said, we would be more than happy for anybody to source it because as I said, it's we do it as a service rather than a financial thing. Yeah.
And how long can patients take MANNOSE if you start them on that and it's working for them?
You can keep it going forever. Okay. There's a small number of people that complain of bloating and things like that, non-specific symptoms, but nothing major.
Okay. And there's been a couple of comments about hip recs for UTI prevention.
Okay. Yeah. So there are parts of the medical community that are very big on hip recs. Look, I tend to only do things if there's evidence for them. Both MANNOSE and UROMUNE have high quality studies supporting their use. I think the data for hip recs is a bit borderline. There's a lot of observational data, so I don't tend to use it, to tell you the truth. I know there are people that do use it, and it may well be effective, but as I said, because of the data hasn't been, there isn't any good data, I haven't been using it.
I think so. You've really followed up one of these questions here, which is trying these things prior to referral if the ultrasound is normal. We shouldn't be referring and waiting for a cystoscopy before we get these patients taking some of these options.
No, the reality with the cystoscopy is that it only has a very specific and limited use in these patients. The reason for it would be if you were getting all of these symptoms, but your urinalyses were coming back with no growth, because that starts suggesting that this cystitis is not bacterial, and then right to the top of your differential list is becoming cancers. So that's really the only indication for cystoscopy. There are very few indications for a cystoscopy in a patient with recurrent UTIs.
Okay. How long does the URINE vaccine last for?
1 year.
Okay.
1 year. So it's 3-month course, lasts for about a year, and then you're advised to take another 3 months. And the reality is that I suspect with time probably we'll find that it lasts longer than that. But that's what the manufacturer recommends, and they're never going to recommend you stretching it out longer than it needs to be.
And regarding ultrasound, are women allowed the same post-void residual as men?
No, that's a good point actually. Post-void residuals in women are abnormal, and so if somebody has any real significant post-void residual, anything over probably 50 mils, the most common cause of it will be something like a cystocele, like an anterior vaginal weakness, and they're not emptying their bladder because of that, and they probably need review in that regard.
So with regards to the treatment of these recurrent UTI women, are you suggesting that we should be holding off on the eradication with the antibiotics and using these other things instead?
Yeah.
And someone's asked, when would you then look at doing the antibiotic eradication instead?
Yeah. Look, So the antibiotics are good in that they're cheap and they're funded. There are significant harms in giving antibiotics. So I personally think that particularly D-MANNOSE, because it's so available, it can be bought at any sort of health food store, or it can be bought online and delivered to their house. I really think it's a really good one to start if they can afford it, basically. But the thing you have to factor into it is the D-MANNOSE might be $30 a month, but how much does it cost to see a GP with a urinary tract infection? As I said, a lot of patients will be prepared to take it for that amount of money. The UROMUNE, as said, is the next step, because, as I said, you need to access it and that side of things. But certainly, I think personally, I think if a patient can afford it, I think D-MANNOSE is a much better option than going on antibiotics.
And last bit, there's been a lot of discussion on the questions here about cranberry juice and the effect, whether it has any effect, and would you ever consider recommending people drink it when they've got a UTI?
Yeah, look, cranberry juice is something that's been around for a long time. It may work. I think the studies haven't really supported it. But things work for all sorts of people in different ways. I don't think there's any harm in it. But whether there's benefit of it is open to debate. And there's probably no reason why you couldn't be on cranberry and any of the other options.
Great, thank you. Let's carry on.
Okay. So just a couple of quick cases here. So if we talk about a 60-year-old man, turns up four times a night, he's getting up to pee. He's got, just to make life easier, we're saying he's got no previous medical history, and his dipstick of his urine, it's normal. So the main thing is what you want to know is it polyuria? So, the 4 times a night of a large voided volume is very different to 4 times per night of a few trickles. The other thing is you just want to look for red flag. Has he got any incontinence with this? That should be an automatic sort of referral on to be reviewed, really. Is there hematuria with it? Once again, another referral. And you want to know what his storage symptoms are like. So what's he like during the day? Has he got urgency, frequency?
Hang on, that could be me. There we go.
Okay. So if you go through his history, let's say he's on some metoprolol but not much else. He's got good flow and large amount each time he pees, and so he stands back from the toilet and he uses the urinal at the rugby. So you're getting a pretty strong history that actually flow's not really the issue with this guy. It's actually volume. He has 3 cans of beer at night. Always worth asking about that, because everybody's got different normal amounts of fluid. Nothing else really to say, and nothing in the way of caffeine intake. So basically with these guys, they should be encouraged, obviously, to stop their alcohol at night, because 3 cans is a litre of urine load. So if you have 3 cans of beer, you've got 3 bladders worth of urine that you're going to pee out overnight. So if he stops those 3 cans, he's going to go down to once a night. The other thing is that, I modified this before, he's on some metoprolol, and let's say he might have a bit of AF. You've got to be wary about subclinical fluid retention in these guys. And you just suggest them to put their feet up sort of on the couch when they're watching TV in the evening, because that's often just enough just to mobilize a bit of fluid. Maybe some compression socks in the evening. You don't need to get stockings, just the socks is usually enough. And that will often settle things down. If he comes back a month later and it's still a problem, then you can consider a bit of touch of furosemide in the afternoon to just sort of start mobilize something of that fluid. But you'd only want to consider if it's impacting on his sleep. Some people talk about desmopressin for this, but it's not the sort of thing you want to do, is start playing around with people's antidiuretic hormone and stuff in the over 50s, because you can get in a lot of trouble with it. We compare that to a 60-year-old, 4 times urination overnight, but this guy now says he urinates small amounts and often doesn't feel like he's emptying. During the day, he's got no problems, but he now often sits on the toilet at night because it's often easier. He never uses the urinal, no history of urinary tract infection, and he's got a big prostate. So this story is quite different, although they're both getting up 4 times overnight. This next guy's highly suggestive that he's got a bit of benign prostatic hypertrophy. So what I tend to do is I tend to start an ALF blocker. It's obviously always your first step. You can give dexazocin or terazosin. review them in a month. And the reason why I review them in a month is you can consider changing across to tamsulosin if blood pressure is an issue. And there's not a lot of pickup of tamsulosin, and I've noticed in primary healthcare. But tamsulosin is basically the nicer version of doxazosin and terazosin. It doesn't have the same blood pressure effects, and it's available for special authority for anybody that's got it doesn't tolerate doxazosin or terazosin. You can go straight to maximum dose, which I think is 0.4 milligrams once a day, and it's particularly good in patients like Parkinson's or hypertension, because as I said, it just reduces that postural hypertension risk. The other thing is I often will add finasteride at this point. This guy's got an enlarged prostate. Your primary aim is to A, make things better for him now, but B, stop him needing an operation in the future. And finasteride's the thing that's going to make a difference for him having an operation in the future. And you just start finasteride, standard dose is 5 milligrams once a day, and as I said, it will take 3 to 6 months to take effect.
Oh, sorry, I do have one question. Is there a PSA needed in Mr. Smith?
It's a good point. The reality is in Mr. Smith, I think that the PSA testing is the same as if you were PSA testing for any other role. Okay. I think the PSA is influenced by finasteride, but I think that starting finasteride is no reason to screen an individual that otherwise doesn't want to be screened, because it's not going to change our long-term management.
How does it influence a PSA?
It will reduce your PSA by about 40%. The thing is, there have been some studies giving people finasteride to see whether it increases the detection of the sensitivity of finding prostate cancer. And people have given it to because it was a chemo preventative for prostate cancer. The reality is, I think most of these studies reduced the PSA in the patient and saved the patient from the urologist rather than from the prostate cancer, because they reduced the PSA threshold so people didn't look for cancer. Yeah. But I wouldn't be too worried about the whole prostate cancer thing. I think that should be managed separately. You know, as a urologist, I often would, but then I've got a bit of time to discuss that through with them at the time. You know, I don't think you'd be wrong in not testing for PSA.
Andrew, someone's brought up here that you've been talking a lot, obviously, about avoiding operations for people for the prostates, but whether TURP is an easy operation and is very successful, and is it better than taking a tablet daily as a different option? Yeah,
well, there's very much different schools of thought. You know, you always get, you know, the good patients get good results from surgery, and we say 95% of the time you'll be fine, you won't have any problems. Unfortunately, for that 5%, the problem is 100%. You know, if you are unlucky enough that you get a major complication like incontinence, you know, that's 100% for you. You know, you're going to regret not having taken the tablet option. So I really like to push the tablet option and want the patient to tell me that they want to have an operation. And the reason for that is that, you know, we are not talking about something that's going to kill them. We're talking about a symptomatic disease. And what's symptomatic and problematic to one person might be fine for another person. So my indication for it really would be them to telling me that it's a problem. Or they can say, look, I don't want to be on tablets, but I always go down the tablet route first.
Okay, great.
So if we look at Mr. West now, another patient, 60-year-old, but this guy's now complaining of urgency and occasionally dribbling in his underwear. No history of urinary tract infection. And he often is sitting in a meeting and he has to leave because he has to go to the toilet. He says his flow's okay, but he stands above the toilet. And he gets up a couple of times a night, sometimes feel like he's not emptying, but it's not too bad. This is a situation where you're talking about the most likely thing is he's got BPH, but he's also got secondary storage symptoms. His bladder's irritated from being blocked off for a long period of time. So what you'll often do with these patients is start them on an alpha blocker first. So although their symptoms of urgency and frequency are suggesting that the bladder is the primary problem here, it's usually secondary to the prostate. So you start them on an alpha blocker, see them again in a month's time, and if they've got, and this guy, let's say he's got some improvement but still some urgency, then you can add some oxybutynin or solifenacin. And what will tend to happen is you'll find that you'll probably be able to get off the oxybutynin and solifenacin as time goes on, because the bladder's getting used to not being irritated so much by this prostate. But if they do have ongoing problems after you've tried that, they need to be reviewed by urologists. And we can actually do pressure testing of the bladder to see what degree of this is the bladder that's the problem, what degree is the outlet, because you're getting in a complicated situation. But it's perfectly safe to try starting both of those medications in the first instance. Now, if we change track and we look at a lady with recurrent urine infections, this is a 56-year-old lady, 3 UTI'S in 6 months, so she's over 2, so she needs to be investigated. Vaginal mucosa looks okay. She's had grown E. coli, no diabetes or anything out of the ordinary. She's not sexually active, which is worth knowing. But she gets some warning, but she often can't get to see the doctor immediately. And that's something that's really important to note, is that some of these patients actually can be managed quite well if it's actually they get treatment in straight away. So she needs an ultrasound of her renal tract, you know. And it's worth getting a urine culture after treatment of the UTI. So you can consider Ovastin. I think the jury's out about the effect of this, but there's not a lot of harm, and some patients certainly benefit from this. You can give them home antibiotics. So what I tend to do is give them Triprim 3-day course, but I give them a pottle so that they can get the urine tested, because you really want to know in these patients whether you're getting a recurrent growth. Because as I said, if you're not growing anything, you start looking for other causes. Her subsequent infections, if they showed no growth or an atypical bug, they need to be referred to urology for further investigations, because your chance of finding something anatomically wrong goes up. If they get ongoing infection but you're growing bugs, you can try prophylactic antibiotics, and particularly if it's E. coli, consider this D-MANNOSE, because D-MANNOSE has got most evidence for it with E. coli. You can use it with any of the other bugs, but there's really pretty good evidence for D-MANNOSE with E. coli. Or you can refer them to the UROMUNE, which is those variety of bacteria. And as I said, that's why it's nice for us to know what it is, so that we can target those specific infections.
All right, so we've got a few questions to go through. So one of them is, can you discuss a little bit about recurrent prostatitis? We'll put up that last slide just so we can go through recurrent prostatitis. And yes, I guess how you would manage it and antibiotic use.
Yeah. So yeah, my brother-in-law's an ophthalmologist, and I said to him, "You are such a lucky guy. You have no things like prostatitis." And he said to me, "Yes, but we have dry eye." And I think every specialty has something like this. So prostatitis is basically it's a diagnosis that's often used as sort of to dump a whole bunch of conditions into. So acute bacterial prostatitis is easy to diagnose. Patients are very sick. You know, they often have a temperature of 40, they'll be tachycardic, they may be hypotensive. You put a finger in their bum and it feels really warm. And if you ever feel it, you know it as soon as you do it, because it feels warm and very tender. Now, those patients need antibiotics, and they often need admission for antibiotics because they get very sick. So we can sort of discount them out because that's an acute septic problem. Now, the group that's far more common and that we see a lot more of is quote-unquote chronic prostatitis. And really probably the better term for this is chronic pelvic pain syndrome. And so there is a small portion of them that are bacterial in origin. Now, the studies have basically shown that if you give a 1-month course of a fluoroquinolone, and ciprofloxacin is the one that we use, there is no benefit from any further antibiotics after that 1 month. We know that prostate infections are difficult to treat, and so you do need to do the 4 weeks. But so what I tend to do is I see somebody in this situation, one of the most important things is say you do not have cancer, because they tend to be very stressed out young people. And you rule out cancer. Then I give them a combination. I give them a course of Cipro for a month, intending on that's the only course of antibiotics they're ever going to get. I give them some doxazosin because there's some evidence to say that that prostate congestion can sort of cause this, and so they get some doxazosin for a month, and they get a 1-month course of an anti-inflammatory. After that 1 month, if they still have pain, they are highly unlikely to have any organic diagnosable disorder going on. And so that's when I tend to send them to a physio, to acupuncture, to aromatherapy, to all those things. I would very occasionally, I will do something like an MRI scan if I think there's some very atypical features or history of trauma or something like that. But the vast majority of these guys will settle down after that month. It will wax and wane for probably until they're in their 50s. But the big portion of it is reassurance that nothing's going on.
Okay, well, thank you. That was a good succinct summary, I think, of it. One of the things that was brought up earlier by someone here was a discussion about the clinical significant risk factors for prostate cancer other than PSA.
Yeah.
So family history, age, or anything else that you can ask us to look for.
I think the main things are PSA, obviously, digital rectal examination. Now, the digital rectal examinations for prostate cancer are controversial. And basically, I think that, for me, for example, I know what a prostate cancer feels like. I know that, I think I'm pretty reliable on my examination. But if you're only seeing one cancer every year or two, you're probably not going to be that reliable. But we do encourage prostate examination, but if it's a barrier, then you can do it just off the PSA, but you are going to miss a few. So basically it's abnormal digital examination, PSA, and the third thing is a family history of young patients with prostate or breast cancer. So prostate cancer is part of the same group as the BRCA group, and so if your patient has a strong family history of breast cancer or prostate cancer, that is a major risk factor. And when we say under the age of 60 would be the diagnosis. So if their dad got prostate cancer at 80, everyone's got a bit of prostate cancer at 80, and that doesn't matter. But if your dad died at 58 from prostate cancer, that's a major risk factor.
And with that, is there any advice on how often if you are going to screen someone with a digital rectal exam or a PSA, how often should we be doing that?
Yeah. So the most common quoted one is a yearly thing, and basically the only reason why it is a yearly thing is that people will see their doctor once a year, and so the reality, it doesn't have to be once a year. You could be really every 2 to 3 years would probably be reasonable. But it's more keeping a pattern going there. So that's why we recommend every year, because people go in for their yearly check to check their cholesterol and diabetes as well.
And in the chronic prostatitis, would you do a PSA in that situation?
Yeah, it's probably worthwhile doing one, just because you want to make sure that there's not a prostate cancer. The reality is that, if you've got a normal PSA and a normal examination, you just need to tell them that they haven't got cancer, and they'll often their pain will improve.
So that reassurance is huge.
Yeah.
Okay. And I guess that's what we want to hang our hat on, is the PSA a little bit, to be able to reassure them, but everything else is important too. Yeah.
Typically these guys are really young, and they're a typical personality. They're high-powered, very stressed out individuals between the ages of 30 and 50. And I say to them, look, I never see guys at the age of 60 with this problem. It'll burn itself out. It'll go up and down, but it's nothing to worry about.
Someone's flicked through a reference saying that they think there is lack of evidence supporting the efficacy of the digital rectal examination. They don't recommend it as a screening tool. Is it similar to the PSA in that there is no perfect screening tool, and you're trying to get a best guess, best estimate?
Exactly. The thing is that it depends who it is doing the examination. Every year I will have 3 or 4 patients that have quite nasty cancers picked up by GPs that have noticed an abnormal examination with a normal PSA. And there's no doubt that those patients have had significant benefit from that being picked up. In saying that, though, if you're not comfortable in your digital rectal examination findings, it's probably not going to be of any benefit.
Yeah.
And it's one of the things we're sort of looking at sort of addressing is, getting some, prostate models on people's desks so that they start feeling comfortable about what's normal versus what's not. But we see a lot of patients in our clinics where it was essentially a second opinion on the prostate examination. More than happy to do that in public. And we see a lot of them, and we just examine it. We feel it's a variant on normal, and you reassure the patient, and they're on their way.
Right, so that's a reasonable thing to do if you're really feeling uncomfortable in a
Very
situation.
much so, yeah.
Okay. There has been A couple of mentions about if you have a family history of prostate cancer, is it similar to other cancers where you're looking for a sort of 10-year gap? You start screening someone 10 years before the prostate cancer that was found in their family? Or what age are you looking at screening someone?
I think the jury's out on this, really, but I think what most people recommend, or most international bodies, is that if they've got a strong family history, you probably need to start checking at 40. And if the average Joe Blogg's 50. Yeah.
Okay. What if there is no family history or any symptoms and you're just seeing someone and think, oh, you know?
Yeah. Oh, 50 is probably quite reasonable. I think, you know, there are a lot of finer points that are going to be changing that. Like for me personally, if I get a PSA at 40 and it's really low, I won't get one till I'm 50. And then if it's really low, I probably won't get one till I'm 55. But a lot of those refinements require a lot of personalization, which gets into very complicated sort of mathematics and statistics.
Yeah. Yes, I think someone's written on here the commenting on the median PSA and screening and versus infrequent screening, you know, above the age of 45 after 5 to 10 years. And I guess you're saying it's very personal and depends on the history, depends on the patient, depends on other factors.
Yeah. You know, a fast-growing prostate cancer, the PSA will double in 18 months.
Oh, right.
So you know, even a fast-growing cancer is still not that fast.
Yeah.
You know, it's and as I said, those with a low PSA actually have a very low lifetime risk.
Yes.
Those in that sort of higher range, you just need to keep a little bit more of an eye on. The higher normal range,
There's been a post-TERP several years down the track. Can you get prostate cancer?
Yep. So a TERP is like coring an apple. So basically all you're doing is you're taking the inner portion of the prostate out. Now the cancers occur on the outside. So often you can have someone with quite nasty prostate cancer and you do a TERP on them and there's no signs of cancer because the cancer is all around the outside. So that's why a TERP does not give any diagnostic ability for prostate cancer. A transperineal biopsy or a transrectal biopsy is the appropriate area. So you certainly can get cancer.
So it could be falsely reassuring.
Yeah.
Yeah. Okay.
Yeah.
So you should still be.
Yeah. So for example, today I did an operation on a guy and I did a TERP and a transperineal biopsy on him while he was asleep. Because I know that although I've done a TERP, I'm not taking samples of the appropriate area, and so I've taken biopsies of his prostate gland as well. He was never going to, this is a patient who will never get surgery, but may get radiation treatment, and so that's why we're assessing it then.
Our TERP's been replaced by green light laser.
No, the reality, everyone's got their little marketing tool. There are a million different ways of coring an apple, basically, which is what we're doing. Everything has pros and cons. So a TERP is good in that it's simple. It has not as many problems with dysuria, urgency, frequency afterwards, and the blood transfusion complications that are actually really low, about 1 in 200 in the Auckland region. The lasers, and there's all sorts of different lasers. There's green light, there's HOLEP, there's all KTP, there's a whole bunch of them. What they do is they basically burn the tissue as you cut it out or remove it. So bleeding's not such an issue, but you do get a lot more problems with urgency, frequency, dysuria following it. And so it depends on which town you're in, which country you're in, which way people do it. And to be quite honest, it actually turns out as, you know, what your local doctors own. Yeah.
Going back a little bit to the patients with urinary issues, how long would you keep the patient on the oxybutynin before you stop it? I think we discussed one of that.
Yeah. I think the thing is basically if the patient's symptoms are controlled, is you just start winding it back. Yeah. So halve it and see how they go. And basically you can just educate the patient to trial it. Sometimes you'll find that they're not actually worried about it during the day. It's just overnight. Well, you can keep going with just the night dose and leave it during the day. It's very much an individualized thing. But you just want things to be stable before you actually start winding it back.
Okay, and there's been a couple of questions in here that I think you've answered already about UROMUNE. It says UROMUNE actually works out less than MANNOSE per year. And it's not an over-the-counter. It's something that we can get through you guys. I think HIPREX, again, someone's asked about HIPREX, so we talked about HIPREX not having the same research behind or evidence behind it that MANNOSE and UROMUNE has. We also have mentioned here that long-term prophylactic urofurantine is out of favour due to interstitial lung problems now, and the ACC are playing claims out about this, so something to avoid.
Yeah.
And I know you've discussed about the MRI of prostates being really good in terms of a test, and if money wasn't an issue, that would be...
Yeah, as I say, I don't have any financial interest in MRIs, but the reality is that I actually see that as probably being the only way that we would look at getting any screening program in the future. We're obviously nowhere near that point yet, but I think what it does is that it helps in reducing harm, you know, by actually not investigating those people that don't need to be investigated.
So rather than doing needle biopsy, you're doing the MRI, but it's cost prohibitive a little bit at the moment.
Yeah, but in saying that, as I said, the insurance companies have accepted that every patient should have an MRI and a transperineal biopsy and are funding it.
Yeah.
And funding it on an agreed sort of a basis, you know, affiliated provider sort of system.
Yeah.
And as I said, I'll do some stuff with the Ministry of Health, and the Ministry of Health has already done the numbers on making sure and looking at every patient in the country getting an MRI scan, and are actually working towards that, get capacity in place with the expectation that that's where we're going.
So it is the future, you think?
Without a doubt, yeah. As I said, you know, a transrectal biopsy is, as I said, probably one of the most sort of medical things that you can do. It's very, very gross and sort of, as I said, very non-specific.
Right, the last couple of things here, Robert, I think with the nitrofurantoin, we talked about the found interstitial lung disease problems with it, so that's why they're not using it anymore. And something that has been partially answered, if someone is low risk and has a low PSA, what is low, less than 1 or below the medium, how often should they be screened, assuming they are asking to be screened? So I guess that's a
with someone with a low
question.
PSA. Yeah, as said, you know, the difficulty with the low PSA is realistically the lifetime risk of prostate cancer is very low. You could probably talk about every 5 years, realistically. But the thing is whether you'll remember it every 5 years. You know, if you've got a good recall system and you will remember it every 5 years, fine. But what most people do is they just do it every year because you catch up with them every year for a checking of other things. But as I said, if you have a PSA less than 1, it is probably quite safe to do it every 5 years.
All right, I think we have covered every question that's come through. Hopefully we've got everything through for you guys. And thank you, Andrew. That's been an amazing presentation. I think there's lots of information that has come through for us that will actually change our prescribing and the way we go now. So I really appreciate that. And thank you, everyone, for coming along and attending.
No problem. Thank you for having me.
Good night, everyone.